Good morning, everyone, or evening if you are in Europe. I'm gonna maybe wait like one more minute and see if anyone else joins us. And then I don't have any questions that were submitted in advance. So if you guys have questions or anything you want to talk about, if you want to come on camera and ask or unmute yourselves, you can do that. If you feel more comfortable doing it by chat, you can do that. But we'll just basically have like a little group session today, since I didn't get any questions that need to be answered first. So see if I can pull up the chat. Can't pull it up while I'm also looking at people who might want to come in. So yeah, after this, I'm doing the last food Q&A in the reboot. And I know some of you are in that reboot, and I have a ton of questions for that. But if you're doing the reboot and you know, this is the last Q&A because this is the last week of the 4 weeks, but the egg quality diet is 3 months, not just 1 month. If you have questions about things related to that, we can talk about that. And also like thinking about it just in terms of like looking ahead and how does phase 3 translate into phase 4, and how do you reintroduce foods and things like that when there aren't going to be multiple weekly like reboot Q&As and emails and things like that. I'm trying to encourage people to think a little bit ahead. You guys have so much luck because you have all this support built in, so you're not really losing the kind of regular contact and structure and support that the people that are only in the reboot will lose after the week ends. But yeah, anybody have a question or want to like start us off with anything?
Sorry. Hi, Sarah.
Hi.
So I know I've got some emails from you, and I will be coming back to you, but I just wanted to know if you've heard of the ARGC clinic in the UK, or if you know anyone that's used them.
ARGC clinic. This website doesn't look familiar to me, although they could have rebranded.
So they have like, I mean, I think their protocol is a bit rigorous. So what they do is I've spoken to someone briefly, and they have 4-week waiting times for an initial consultation. But basically the way that they operate is if you have to have the consultation first, but then they do like not a mock cycle, but they track your cycle for a month before they start you on treatment. So they make you not make. I guess it's voluntary if you want to use them. But they blood test you every day. So you have to go in every day. And then once you're having the treatment, they adjust your medication based on the results of your blood test in the morning. They apparently have higher than average success rates in the UK, but none of their figures are for anyone over the age of 42. And also I read in a blog somewhere, but from about 2014, that their medication dosages are high, but I don't know what it is because I haven't had a consultation there directly. So I mean, plus it's about 2 to 3 times more expensive than doing it anywhere else. Because you look at the prices and they don't look more expensive, but because you have to pay for the blood tests on top of everything every day, it works out more expensive. I'm not necessarily sure. I know finances for me are a bit of an issue, but I think I'd be prepared to pay it if it was increased my chances. I just don't know how they would work with you guys and like looking at the medication? Because if they tell me to take a really high dose, and I don't know.
Oh, um, so uh, what I would say, based on what you've said, is that that concept of doing a monitored cycle in that way, where they test your blood every single day, is something that I have seen from some of the Catholic fertility practices here in the United States. We have some, I mean, Catholics exist everywhere, so it's probably true in other places. Catholics don't allow or agree with all aspects of IVF because they have religious concerns about embryos being children, being frozen, you know. And so a Catholic woman um, has access to a Catholic fertility clinic in the United States in a lot of places where they do some things that a regular IVF clinic does. Like they definitely use some of the medications, things they do ultrasounds, they do monitoring, they do trigger shots, they do all kinds of things, but they don't do a few of the things, which includes like making and freezing embryos. And one of the things I have seen in those clinics is this I wouldn't say that I've seen every single day throughout the entire cycle, but every day in the follicular phase, doing a tracked cycle with a girl when she first gets started. And it, to me, it is the like, I'm making this up. This is only how I think of it in my head. I can't promise you that this is real, but in my head, the way I've always thought about it is that it is the like medical doctor led version of BBT charting, which also like basal body temperature as a way of identifying when you ovulate and getting pregnant was also invented for Catholics who couldn't take birth control as a means of avoiding pregnancy. So it's like a, to me in my head, it's a doctor led version of that. So it's a way of using like resources that are no longer used as frequently in the like standardized IVF world because they have made efficiencies. If we went back in time and we were looking at what a woman in the 70s or the 80s was being asked to do in a fertility clinic, my guess is that she was being monitored much more often. And they have just kind of pared it back. So I don't think there's anything wrong with that. And I think that if I had more experience with more people, I always have like one or two girls that are at these Catholic clinics, but not really more than that. We might see that it told us something, told the doctor something that the less frequent monitoring in a traditional clinic does. Certainly, like you guys know by this point from having been in group sessions with each other that like how women who use a system like Mira or UVA or Anido to track their cycles at home with like home testing that gives us a numerical value for the different hormones on every day, we see some things that are not textbook on a regular basis. Like we see low surges in progesterone before ovulation that are not really explained by medical texts. Like the concept is that progesterone should not be able to rise above a certain level until after you've ovulated, because the follicle that you've ovulated out of is the only place that can make progesterone in such high a level. But occasionally we see not a crazy high, not a sufficient level to support pregnancy, but like just tipping over the number that Mira will say confirms ovulation, and the girl hasn't had an LH surge yet, and then she goes on and has an LH surge like 2 days later. I stick a pin in some of that stuff because we're looking at urine, not blood, and urine is affected by like how hydrated you are and how recently you peed and how your body breaks stuff down. So I don't know that it's an exact like comparison, but I do think that you probably do see a few things about women. My suspicion is that you see those things about women whose cycles are more irregular. So if you are a woman who has an early LH surge, which definitely some of you do, maybe not some of the ones that are on here, but some of our girls do. Like, there's a girl in one of the groups who she gets an LH surge. I'm not going to remember exactly what day, but maybe she gets it around like day 9 or 10 of her cycle, and she gets pregnant and she's had some losses. But there's like, we're talking now, and her doctors are talking now about how there's concern that maybe her eggs aren't actually mature yet at the time that her body surges, and maybe that's part of the reason why she's having some of these issues. And so I would think that a woman who has some issues like that, where there's been some maturity issues, where there's an early ovulation, where there's a very low, kind of like minimal LH surge, not a very robust LH surge, my guess is that we would see more that we might learn that might benefit the cycle from a girl who has some of those challenges. So if you have a more typical kind of textbook cycle, maybe it's not as big of a benefit for you. There are the idea that then they use that information and they adjust and tailor the medication every day of the stim cycle. That is also like, it's higher touch, right? It's like more interaction with you. It means that either they've empowered their nurses and like support staff to be able to make medication decisions, or that you're getting more review by the doctor. And that potentially is a good thing, right? To have more review and more contact with the doctor. A lot in some clinics, it's incredibly hard to get any confidence that the doctor's really like paying attention to your specific cycle at this specific moment. And there are some doctors in other clinics who do a lot of changing the medications throughout the cycle. I wouldn't say that it's literally every day. I've never really heard that. But in this like spectrum of like types of IVF stim cycles, you know, I sort of always envision it as going from like conventional traditional high at its highest point, and then the other end is like the absolute lowest point of low stim, and then there's a whole lot in between. One of the things that we're seeing, I think, more of, but not in all clinics, only in some, is the timing of the medication. So starting with one med, like starting with a gonal F or something, and then only introducing Menopur later in the cycle. Or for some people, starting with a certain dose of Menopur and then like starting with a higher dose of everything and then dropping everything down, or starting with a lower dose of everything and then increasing everything high, vice versa, like some of this. And so that, to me, what they're doing falls along somewhere in that spectrum along with those folks. And they definitely claim higher success. But it is a smaller group of people, a smaller number of clinics. And so it's hard for me to like have seen enough people for enough time. Because I'd say I started seeing this like a year and a half or 2 years ago. It's hard for me to know how much more successful it is. But I don't think it's bad. I think being responsive is good. I just don't know if it's worth all the extra time and money. Because every woman's body is different. So,
I mean, it doesn't look like a Catholic clinic. I look at the doctor's profile. He seems Middle Eastern.
I looked at them too, yeah.
And I think somewhere I did read, like with reviews, that it is mostly the nurses that you said they've trained them to have a bit more higher touch. So I think it isn't the doctors that you see every day, but it is maybe the nurses consult with the doctor, and then they call you and they tell you what the medication dose.
I mean, that's extremely typical of like all fertility clinics. Like most of the communication is with a nurse or a coordinator of some kind. Yeah.
So I just don't. Well, I mean, the thing is that it's a 4-week wait for a consult, and they've provisionally booked me in for the 13th of March, which is ages away.
So
Um,
you seem to be really exploring all opportunities, all different options, and trying to, like, when I first met you, um, it seemed like you had a plan sort of for a transfer with the clinic that you have been working with, which is your second clinic, I think, right?
well,
That you also then were entertaining the idea of a retrieval, and you were
yeah,
thinking, you were thinking maybe about Cyprus. And like, I'm not complaining about this at all, but it seems like now you've like opened it up and you're looking at a lot of things, which
well,
I think is fine, but I also think it can be really confusing.
yeah, no, it is. The clinic that I was originally with is based at the London Women's Clinic, or was, and they left and went somewhere else. But my eggs were stored at the London Women's Clinic. So for me to, because what I wanted to do at that time was just for them, um, fertilize them and see if any are tested normal. So I thought it was easier to do it with the same clinic that they were stored at, that rather than go somewhere else. So that's why. So they are technically, well, there's, I think they are the second clinic, but the they're still the same place where my original treatment was done. That makes sense. Um, I explored the others just because I wanted to do the PRP treatment, but I don't necessarily feel 100% comfortable staying there to do the future treatment. So I think in my head, I wanted to go to Cyprus, but then I had the laser therapy, and the therapist there talked about this clinic, and I was like, I'd never heard of them. So I thought I'd look into them. Um, and then I got confused again. So yeah, I think I'm getting a bit, I don't know where the best place to go is, and I just want it to work. So
Yeah.
I keep reading into things, and then I keep asking you questions, but they have a different. So I think my worry is I wouldn't mind going there and paying the higher fee if it's more likely to work. But I think my worry is with the PRP, I don't want to lose the window, because if they don't have a consult until March, and then they do a monitored cycle, and only then do they start treatment, is the benefit of having the PRP last week going to even matter? Because it's so it
Yeah, it's starting to get a little far into the future. PRP is sort of like a 3 to 4 month window of impact. And it's a little bit different for each woman. Sometimes it lasts longer than that. Sometimes it starts very quickly. And so you have the PRP somewhere close to ovulation in like January. And when you go in for monitoring for your February cycle, you have like a higher number of antral follicles that appear to be kind of recruiting and like ready to go, or your FSH has come down like dramatically from where it was before. And so that woman's body is like ready to go. But some women will go in for that February monitoring and be pretty disappointed because they've just done the PRP and it has all this, potential impact, and like they want to make sure that it was effective, and then everything looks the same or like one of their worst cycles,
yeah.
right, at February. And in the absolute extreme, some girls, especially women who have like extremely low AMH, who are either like um, in their later 40s, or more often what I'm seeing is in the really young girls who have some type of like family history of entering menopause very early. So we can be like a 28-year-old girl who's having this experience where she's not even getting a period, so she doesn't even know when to go in and be monitored, even if she was getting regular periods before the PRP. And that like can be because in those more extreme cases, the ovaries they're kind of delicate, and like her body is struggling already, and doing anything, including the little injections into the ovaries during the PRP, can be a little bit temporarily traumatizing. And her ovaries kind of like take a pause. They need time to just heal and like recover from the trauma of the procedure itself. It is not the most common thing to happen, but I have seen it happen a few times. And what happens there is that her ovaries take one, or even in the long, like most extreme cases, 2 cycles of just kind of doing nothing and then start to respond. But in the cases of other girls who just don't see like their best, they don't see a positive impact at their monitoring in February, then they may decide not to go ahead with the cycle in February and wait for March and then go in and monitor. And we are expecting to see that there is that impact there. So the girl who's had the immediate impact, maybe it wears off sooner. Maybe her months are like February, March, April, and then it's kind of over. But maybe it lasts into May or June. And the girl who has it take effect later, so it doesn't take really like have as much impact until March, we can't necessarily say that she's adding another month later on. Her months still be maybe March, April, and then maybe May and June. And that's part of the reason why when women are going to do multiple retrieval cycles, they start to repeat the PRP as part of the retrieval. So do a PRP, do a retrieval and a PRP, then do another retrieval, because it starts to extend out that effect, and the effect of the PRP kind of like builds on itself. But it is true, like I listened to a talk that Dr. Murphy gave a few weeks ago on like a podcast, and someone asked him this exact question, like, when should I expect it to take effect? And his answer was, I can't tell you. Right?
Yeah,
it's
the clinic that I had the PRP with, they said to call back on day 1 so I could go in and get the blood tests and stuff, and then I consult afterwards to see what the next steps are. So I figure I'll do that anyway, just to see if it has worked. And that is likely to be before this other consult. So I guess I can have a look and see whether or not it needs.
Yeah. So on your day, on your like early monitoring, the things you'll be looking for, they'll monitor all the normal stuff, but you'll be looking at your, you'll share it with me too, but like, we'll look at your FSH, your estrogen, your progesterone, your LH, right? Those are the basic things that they're looking at. And we're hoping to see that your estrogen is in kind of like the optimal range, which is, with American numbers, it's like 50 to 70. And then maybe like 50, 60. And then that your FSH is below 10, that it's nice and low, and then that they see and count a good number of antral follicles. And every clinic, it frustrates me, every clinic does the antral follicle counting differently. So because you've done the PRP, I would be specific and ask them, say that you did PRP and you're specifically interested in how many follicles they're seeing and what their sizes are. Because if they don't know that they're going to have to provide you that information before they do the count and take the notes, they can't necessarily go back and like recreate that. And some clinics do count the really tiny ones that are like below 5 millimeters, and some clinics don't count those. They just say like, and there are some in that size. And maybe you're looking for a more numerical value, but there is another value that you can't see at monitoring that will also like be impacted by the PRP. And that is what happens to those follicles when they get exposed to medication. Because in a natural cycle, which is where you are when you go in for baseline monitoring, a small number of them should really like recruit and do anything, because our bodies are optimized for us to just have a singleton, to just get pregnant with one baby. Whereas when they get hit with the stimulating medications, we're expecting more of them to recruit and like get respond. And one of the things that the PRP does is help those follicles not just to exist, but mostly to be responsive. So it is like, you're looking for a good number of follicles and you're looking for good bloods, but you don't even actually know how responsive, how effective the PRP has been until you start stimming.
Okay. So just one last question. I know I've taken up the time. So with the PRP, I know the normal cycle for an X, based on the book and everything, is like 90 days for it to start from scratch, to start develop properly. So does the PRP just enhance what was already developing, I guess is what I'm trying to say, so it doesn't necessarily take the full.
So as far as we understand, we are born with all the eggs we're ever going to have. And the way I think of them in my head, this is a little bit true, but this is mostly me like putting it into terms that I can visualize. You think of the ovary as almost like a planet, you know, like the earth, right? And at the core of the earth are all these like potential future eggs. And what's happening as they are maturing, not maturing like they do in a single cycle, but as they are kind of um, like engaging and like participating and moving towards being able to be mature, because there's a long process that goes into that. They're kind of rising through the layers of the earth, the layers of the ovary towards the surface. So the further towards the surface that they get, the more impacted they are by what's going on in your body on a day-to-day basis, right? They're still not most of us have an awareness of how certain things in biology work with what we call receptors, right? Where like we'd call estrogen a hormone. The hormone has to meet a receptor on a cell in order to make something happen. And we think of that as like a lock and a key situation where like there's a receptor and then the estrogen goes in and then that causes something to happen. And then eventually that estrogen will kind of like drop off and then another estrogen will be allowed to enter that lock and then another thing will happen. So they don't have receptors on them. They're not getting like actual personal engagement with the hormones in your body, but they are existing in the scope of your body. And so the overall healthy functioning of your body, both full body. So when we're talking about things like insulin resistance and blood sugar levels and like chronic full body systemic inflammation and reactions to people's autoimmune diseases and like all of these things, this is playing a role too. But even just on this like really specific level related to PRP, related to these growth factors and like hormone receptivity, you can think of the stages of the ovary that are like close to the crust of the earth, that are like the next few layers down. They are like I don't know what the best way to, but they are aware of the hormones. Like they feel the vibration, or they like recognize the consistency of like the connecting and then the affecting and everything. It's like they're along for the ride, kind of, right? Like they're in another car on the train or something. So they're being brought along, but they're not actually engaging. And we see more and more and more impact as we get closer to the month that those eggs are going to be the ones that are on deck, the ones that like are at the crust, the ones that are ready to ovulate. And we have the most information about the 4 months before they get there. So it's not necessarily that anything in your body is not also impacting the eggs for a year from now and 2 years from now and 10 years from now, that are kind of like at the core of the ovary that haven't started to like rise to the surface. But it's that the further they get towards the surface, the closer they get, the more that they have changed in their structure and everything in response to becoming closer to being ready to mature. And they have done that change in response to this like kind of environment of hormones that they have been existing in. And we also just happen to have the most information about them because they're the most visible to us. Like they're the most possible for us to study. So it does impact the future eggs as well. How much is very hard to measure, but it does.
Okay. Hopefully everything else that I've been doing would have also already impacted those, but
yeah. I mean, it's part of what's like, it's part of what's so commendable and like impressive, and like that I think you guys should give yourselves so much credit for, that you are willing to put in this work for these small percentages of change, right? They are the percentages of change that we have control over. So of course, like, I'm not saying that someone should just say, meh, I'm not into that. I don't want to do that. Like if we have the opportunity, but the reality is that unless you are a woman who has a really severe inflammatory condition, like she has some type of Crohn's disease and like is pooping her pants all day, every day, and there's blood in her stool and all kinds of things, she can make some changes that could have some like super dramatic change. But a girl who has like some achy muscles and achy joints and like doesn't feel like she sleeps that well, and she ends up like tying it to some like painful to her in the day to day, but relatively small changes to her diet. And then she sees that she feels better because she's not drinking alcohol and she's not eating gluten and she isn't eating as much sugar and she's left out, the 2 nuts that she really reacts to and like everything. She's not getting the same dramatic effect that the girl who has blood in her poop all the time is from making these changes, but she is making incremental changes that have an impact. And we can't measure them literally. We can't say when you do this, you get 2%, and then you do this, you get another 2%, and then you do this, you get another 4%, and now we're at 8%. And look at that. And we do one more thing that we add in PRP. Now we're at 15% more likely to have, a euploid embryo or something like that. I wish we could measure it like that. But that is basically the trajectory. That is basically the work that you're doing. And that's why I think you guys should be really conscious of how strong you are, that you are able to like show up and do this work for yourself when it is small increments for a lot of effort.
Thank you. I am going to stop talking, I promise. Yeah. I was saying that the lady that did the laser therapy said, when I was giving her my background, she said, well, you're very strong. So she also said something along those lines because, especially doing it by yourself and then doing all this extra stuff, it's not easy to do it. But yeah. Anyway, thank you.
My feeling is that the biggest decision for you is Cyprus or UK. Which clinic in the UK is a big decision, but I think that you have to kind of make a decision about like local or travel. And then, one other thing I think you can do is you can post in the Mighty Networks in the FFP group and see, because we have other girls from the UK from previous cohorts, like maybe some of them will give you their experiences on specific clinics.
Yeah, so I did that already after the group call with Sam. So I did that she said to do it in the yes, you can get pregnant because
there's more people in there.
Yeah, so I did that. I haven't had a reply yet, but I have done that. So
go back in and like re-up it or ask again, because you have to also hit people at the moment when they like actually have time to respond, and there may be some people who saw it and thought, oh yeah, I should say something about that, and then they just didn't do it right then, so they didn't end up coming back to it.
Right. Thank you.
You're so welcome. Anyone else have a question that you want to ask or something you want to talk about or share anything?
I could pop it. Oh wait, it looks like other people were. Okay. Well, I'll just be fast. Sorry. So I'm having issues with and I was complaining about this on the call with Sam, but I'm having issues with trying to locate, and I'm in Chicago, like someone, I guess, who can do, like, my osteopath is really like on to me about having some genetic testing and that sort of thing, and trying to find somebody that will like A, see me in a timely manner, and B, see somebody that's 45 or whatever.
You say genetic testing, do you mean the kind of testing where they test you and your partner to see if you will if you are carriers of anything, or are you talking more about like looking at your genetics in terms of the SNPs in your various genes that like make you potentially likely to have something like MTHFR or some other like blood clotting issue or other stuff like that?
Well, the MTHFR, I'm going to get tested separately. And we did genetic testing to see if we had any issues. So we've done that. Not like a full panel, but the things that would have made sense for us. But he's kind of, the problem I'm also having is I guess he's looking specifically for me and some issues that I might have. And it's difficult to even, I'm like, well, what kind of tests or what specific tests? And it's like unclear. And I didn't do the 23andMe just because I don't feel great about 23andMe.
Yeah. I understand that.
Yeah. So I guess I'm just having a difficult time trying to figure out what next steps I can do. There is an OB-GYN that I'm on the list because my other OB, when I got pregnant, she dropped the ball. And so I'm looking for another one post miscarriage. So this other one, I can't even get in to see her until May. So I don't know. I'm just trying to figure out if there's another method of being able to get, and I know that like I have concierge doctors, so they would order it if I asked, but he wants somebody that would be able to like read it a specific way. So I don't know if you have any suggestions on this, but
so functional medicine is kind of a broad umbrella. My primary care physician she is just a primary care MD here in New York, but she has a functional medicine approach. And years ago, she ordered a genetic panel on me, and I have like 100-page PDF results of it. It was pre-pandemic, right? But it did cost me $1,200 out of pocket, I remember.
yeah.
And then every year when I go to my physical with her, she pulls up her version of it, and apparently it updates from, they add new information as they get new information, so it's a living document on her end. And she uses that. That's how she identified that I have a blood clotting factor issue and other things. So I do think seeing a functional medicine practitioner could be the entry point for you into this, but you sort of would have to ask their office if they do genetic testing. Are there specific symptoms or concerns? Even if your osteopath can't give you a list of tests that's comprehensive, you could ask if there are some exemplar lists, tests, like 1 or 2 or 5 or 10 tests that he thinks should be included in whatever you're doing, even if it's not a comprehensive list, just so that you have an entry point with someone to be able to get an idea of whether they do what he's looking for, but also they will have a better idea of what it is that you're showing up and asking for help with. Because if you just come in and say, please help me, but I'm not really sure why, you're not going to get a lot of help from them.
Yeah.
And then I think the other thing to ask for, or if you know it, to tell me, is like, what are the specific concerns that he has, or what are the areas that he's trying to navigate and like investigate more, because that can also help us like figure out not just what type of testing you might need, but if you had a choice between a functional medicine like a primary care who practices functional medicine, or a like functional medicine practice that has like nutritionists and other people in it, or a gynecologist who practices functional, like we might be able to pick and choose which practitioner would be best too.
Got it. So I have 2 functional practices that I work with. So I could, and that's what I mean is like I have a team that could do it, right? That I think would be okay with to do it. My problem is finding a GYN that's like functional and that gets, I have a concierge GYN, and she used to do OB, but now she's just GYN, but she's kind of more of the thought like, oh, you're too old kind of vibes. So yeah. So she would order it for me, but I feel like she would think it's a fool's errand, so that's why
I'm gynecologist has to be able to read it too. Like what your osteopath is saying is that he's not capable of reading it to the extent that he wants it read, is what I'm getting.
Yeah.
Because I would feel the same way. Like I know a certain amount, but I don't consider myself I consider that to be like out of my primary scope. I wouldn't feel like I could give someone everything that they should be getting from a set of those tests. So
And I would say that some of the things that he's more concerned about is because, you know, he did family history too. He's kind of more concerned about like diabetes sort of things and heart stuff and like autism and, you know,
Autism for you or for your offspring?
offspring and that sort of thing. So I think that's kind of the main things he was talking about. I'm looking at my husband. And I guess he's a little spooked because he had an incident where, you know, they didn't do genetic testing and the kid got like some kind of shot or an MMR or something like that, he said. And then the kid was autistic within like, you know, an hour of the shot was what he's saying. So, yeah, I don't know. I wish I could just find an OB that was not telling me I'm
And you certainly need an OB when you are pregnant.
right.
And that is like in the scope of finding a women's health practitioner, that's the easiest and most timely way because that's the way that's organized for people to suddenly need someone.
right.
And probably need an MFM also, who
Right.
maternal fetal medicine specialist, whether that is within the same practice or whether they just are separate practices and you see them both. That also is fairly easy. Sometimes you can get in with an MFM for like a consultation based on your previous history of loss. And the MFM sometimes is someone who will do some pre-pregnancy care and testing because you have the history of previous loss. So that is potentially a place that you could look if you're like struggling.
She's the one who I've got an appointment with in May, and
Yeah.
I believe she was the one that like I went to see her in 2017 when we initially did the blood work, and she did the testing to check us against one another. So now I won't be able to get in to see her, the MFM OB, until May. But you know, I want to make sure I have the other, like if there's just a regular OB, you know what I mean, in place.
Yeah, the regular gynecologists are a real struggle. And even in New York City, I have a hard time referring people to them because different people's insurance, you know, applies in different places and like it's a big headache. I would say that from the perspective of the like concerns about autism in your children and impact from any vaccines or other things that they might have, you do have some time to figure that out. Like those are not things that are related to the chromosomes in an embryo, for instance, that we have the ability to test anything for at this point in time. The things that they test, whether you're doing IVF and testing embryos or not, but just like in terms of the tests available, the tests that are available for an embryo really focus on chromosomal abnormalities. So aneuploidies, like whether there's a monosomy where there's only one copy of a chromosome or a trisomy where there are 3 copies instead of 2 copies of a chromosome. And then what known genetic like disorders, diseases, and like birth defects and kind of like interference with the ability to live there is. And there isn't any testing of those things that is going to be available to you until like that would make much difference in terms of what vaccines or what vaccine schedule you planning to put your child on, which means that for some type of genetic testing for you, you can have blood drawn at any point during your pregnancy. Like we're not concerned that that is somehow harmful for you. The things that we do when we are pregnant to try to minimize like harm and risk to the baby. I mean, one good thing is that they do monitor, and in a city like Chicago, you're going to get almost as much monitoring, if not as much monitoring as we do here in New York. I always say that in New York, we're aggressive consumers of healthcare and that we push the boundaries, we push the expectations, so that like the girls that live in Idaho and, you know, other places eventually do get more care because we push the standards. But it is definitely true that if you live in like a big urban center, you're getting more care. So
Yeah.
you will get a ton of tests during your pregnancy, and the things that we focus on, like making sure you're getting methylated folate, not just folic acid, and that you're getting sufficient methylated folate, and that your diet has a sufficient source of choline and glycine, and that you are managing the intake of protein and fat to be higher, because they are important and good for you, but also managing the intake of carbs and like sugars to be lower because they are problematic for different things. The way that we focus on blood flow and, you know, recommending a low dose aspirin in a lot of cases from the very, very beginning, like you probably should be on a low dose aspirin from ovulation in every cycle. And part of that is because there has been some really interesting studies that have come out where they're looking at what they call placentation, which is like the very early beginning stages of laying down the like roots of the placenta. So like an embryo has a core and it has an outer ring. And when they do the genetic testing on it, they take cells from the outer ring. They don't take them from the core. The core becomes the person and the outer ring becomes the placenta. And so from the minute that the fertilization starts, well, maybe not the minute, but let's say from the second or third day after fertilization has started, we're already starting to build a placenta. And even before implantation has started at like day 5, 6 after fertilization, that has already started to be affected. And at this like exact moment, the connection between the mother's body and the placenta is starting. And they're finding that in those first like 5 or 6 days, blood flow and circulation is really critical to how that placenta will function in like week 25 and 30 of pregnancy. So a lot of the stuff that you're doing with us is focused on trying to cover all these bases that your average medical doctor isn't like set up to test you for and like provide oversight and recommendations and things on. So I think that you have a little bit of time to do that genetic testing. If it's a struggle to get in with someone, like I would focus on probably getting pregnant, and having a healthy body. And then I would be feeling like I still had the, you know, first 5 months of the pregnancy to kind of like sort out some of those other tests. Does that make sense?
Okay. Yeah, that's super helpful. Yeah, he's indicating that certain parts of his, you know, treatment really are reliant on the test, but I think we just do what we can.
The metabolic stuff is fairly easy. Your primary care physician should be able to run a complete metabolic panel for you.
Okay.
That would be all the cholesterol, all of the hemoglobin A1C. They can even do additional testing beyond that, where they do, like, you could do a glucose challenge if your doctor's really concerned about it, and see how like what your fasting glucose is, but then also you can be given a source of glucose, and then you can be tested at 1 hour, 2 hours, 3 hours afterwards. And they can do the same with insulin. And those are like deeper tests that give more of an indication. I have a girl right now who everything looks perfect on her except her 1, 2, and 3 hour glucose challenge. I mean, she looks perfect metabolically. Like, there is nothing in the rest of her tests that would suggest something. And based on those glucose challenges, her doctor is calling her minimally pre-diabetic, but possibly diabetic. She's having to repeat everything because obviously, like, there can be an error and stuff like that. But your primary care physician, if they're willing to do it, would be able to do that stuff, and your functional doctor could certainly do that.
Okay, I will ask them about that. That's super helpful. Thank you.
Yeah, of course. You're welcome. Any other questions from you or from anyone else?
Hi, Sarah. It's Christina.
Hi.
How are you?
I'm
I
good.
would put my camera on, but I just
You
woke
don't
up
have
and I'm in my PJs.
believe me.
Still early.
I am not a morning person. I just play one on TV. So I
Thank you for understanding. So I just have like I don't know if this is a silly question because I've kind of gone
I don't
down
think
the
there are silly questions.
okay. Thank you. But when I have gone down the Google rabbit hole a little bit, because I just can't seem to get this out of my head. I want to understand.
Yeah.
So we ran some tests. So we ran my labs for my T4 and my TSH. My T4 was within range, but my TSH was like slightly high.
You know what it was?
So it was slightly over 4. It was like 4.1 or something like that.
And
And
T4, they didn't do T3
no, they just did the T4.
and they did
So
antibodies.
you know what? No, these were the only two I think that we did. I had done some earlier tests, but more recently, these were the two that they ran. It was my RE that
And it was
ran these for
RE
me.
did it. Okay.
Yeah. And so I let Amy know, and she was like, just, we need to get you on levothyroxine. Your TSH is a little too high.
Yep.
I did get a positive test, so it's still very early for me. So she was like, see if they
You
can
got
run.
a positive pregnancy test.
I did,
Yeah.
So it's still,
Congratulations.
thank you.
Yes.
Still early, but
We
I'm
want you on
hopeful.
medication for sure.
Yes. And we completely Heather went through my supplements and like I'm on like the exact plan that I truly believe. So the interesting thing was she was like, see if they can run another blood test like a week from this visit just to see. So I talked to my RE about it and she was like, we typically don't run once you start levothyroxine, we typically don't run the labs again until about a month. But of course, right, advocated, we have a good relationship. And she did, and it dropped about half. So it dropped
Great.
to about like 2.2 or something like that. So I'm still on it. And I'm just wondering, like, how does that happen when like your T4 is in range, but your TSH is slightly high? Like Google is telling me all things about subclinical hypothyroidism and this sort of thing. But I'm trying to like get out of that space and just say, okay, my body's responding to the meds. And wondering, is this something that I'm going to continue probably to be on? Or yeah.
The short answer is don't fight the thyroid meds. The thyroid meds are not bad for you. It's a little bit like filling your gas tank, as opposed to changing the way that your body functions. So every cell in our bodies needs thyroid hormone. And part of the reason why it's so complicated and why there's so many different hormones, T3, T4, total, free, all of things is because our bodies have a really complicated system for managing this resource. Your thyroid is up in your neck. And if all the hormone that it emitted just was immediately available, it would only get as far as like your heart and your lungs, and then your kidneys and your bladder and your uterus, your toenails and everything would not get. So it has all these storage forms and this like system of carrier proteins and all this stuff that like allows there to be a circulating volume of hormone that is not actively like engaging with your body, but can be converted and can be made available that way, like freely available everywhere. And we're not reliant upon what your thyroid made in this exact moment. And so when you take you're on levothyroxine, what you're taking is the storage form. So what you're doing is filling the tank so that when it's needed, it's available. And if you stop needing it after pregnancy, then you stop filling that tank extra, but your body is in a different situation and it's able to fill the tank sufficiently. What it's not doing is changing how the thyroid makes the hormone. Your thyroid is going to continue to make hormone while you're on it.
Okay.
So thyroid is insanely complicated for everyone. Like it's not weird that it's hard for you. It's also not odd that it's hard to find stuff online. Like the standards that are published by the endocrinologists, and I found this to be true in all the countries that all of you guys all over. I have never found this to be different in any country. they don't even agree 100% with their own standards. The endocrinologists publish, right, like the normal range for TSH, and then they treat differently than that normal range. One of the places where that happens is in women who are trying to conceive and are pregnant. And so it's the range for TSH that is acceptable becomes smaller when you're in this group. And so you're never going to see a lab test come back saying that your TSH, if it's a 3.8, is high. It's always going to say it's normal.
Right.
Know that it is treated as high situation.
Yeah.
And that's like so frustrating.
Yeah, they didn't even flag it in the beginning. And I'm, sending my information to Amy and I'm like, everything looks great. And she's like, wait a second.
Yeah. I mean, the reason I want you to test the TSH right away in pregnancy, what I always say to people is you go in for that first blood test, they're going to test beta HCG and progesterone, and I want both numbers. And then you go in that second beta 2 days later, and I want those two numbers plus I want TSH.
Right.
There are a very high number of women who have it rise, who never had a thyroid issue in the past. Now, the standard for how long you wait to test is pretty much like after you've started the medication, how long you wait to test again. The standard is kind of 6 weeks, like to read everywhere. And you're saying like a month is mostly because if they said 6 weeks, you would already be with your OB. By that point, they wouldn't be testing it again. But that is, again, much like the range for TSH, not how they practice. So if you were already known to have hypothyroid and you already had an endocrinologist, they would be testing your thyroid hormone potentially every week in these early weeks of pregnancy, especially if they were changing your medication. So even if you were on medication and changing it. And in my experience, because I see so many people who do get tested 1 week or 10 days or 2 weeks after starting or increasing their dose of medication, your TSH does respond within that time. I literally just said this to someone in the clinic the other day. It does respond. So this like waiting 6 weeks thing, I don't know where
it was scary when she said that. Right. Yeah. And it just felt more empowering to like know that the value did change that significantly and that there was no conversation like, oh wow, like great job, like it was just kind of like, okay, I have your OB, like continue on with you.
Part of the problem here is that regardless of any of the additional details, the doctors see themselves as having only one choice, one option to medicate with this particular medication or another one that's basically the same or not. Right. And that's not just true of your reproductive endocrinologist who's working like, tangential to their primary focus. Their primary focus is estrogen and FSH and, progesterone and everything. And then TSH plays such a big role that they like get a little involved, but they don't see themselves as being your primary doctor for that, even though they've tested it and prescribed you medication. They want you to see someone else. Some of the endocrinologists also really act like they're hampered by this. Some don't. And that's the same situation with all doctors. Like, great doctor, you have a great doctor. When you get a shitty doctor, it's a real problem. And then there's a bunch of people in between. But the reality is that the treatment protocol for hypothyroid is give thyroid hormone. And that's it. Like the treatment protocol for hypothyroid with elevated antibodies is still give thyroid hormone. Now, they should also want to do other things related to the antibodies. And some of them will, and some of them won't. So it is much, much bigger than what's going on in your body. And unfortunately, it shapes the way that you have to advocate for yourself and the information that's available to you about what you're even doing to support your body in a way that's unfortunate because it shouldn't be your responsibility. What I would say is like, I fully expected your TSH to respond to the medication that you were given
Mhm.
and for the test result the next week to come back with your TSH in the normal range. And it is really good that you got the test done and that you confirmed that, 'cause
Yeah.
now you can sleep at night.
Exactly. Yeah,
Like-
exactly.
Sometimes we're doing these tests for, multiple reasons.
Right.
Right?
Right. Right.
You should see an endocrinologist because
Mm.
you're pregnant.
Mhm.
Your OB in theory might feel comfortable managing this, but depending upon your age, depending upon your past history, depending upon all kinds of things, you may also be seeing an MFM in your,
Right. Yeah.
and that person may manage your thyroid. And I'm a little more like on board with that person managing it than just
Yeah.
your OB. So if
Yeah.
you're going to see an MFM, maybe you don't need an endocrinologist,
Right.
but I would see one or the other.
Okay. Yeah. She did say that because the clinic is so busy that, I would graduate to my OB, who she actually recommended and worked very closely with. So I'm assuming they have a similar way of, just listening and being open to doing things. And I'm going to see her this upcoming week. But she did also say, like, I think just because of, your history and of loss and all the things, that an MFM would just be a good additional support.
I really like it when you can see an MFM. I mean, it complicates your life. It's more expensive. It's more
Mhm.
appointments, things like that. But it
Yeah.
offers you two opinions.
Yeah.
And I find that, like Erica was talking about, having a doctor who's supportive of her at her age, for instance.
Mhm.
I find that the MFMs are a little less freaked out by an older woman.
Mhm.
Everybody
Yeah. Right.
expresses their, liability related concerns,
Mhm.
but like the MFM just naturally works with folks who are higher risk. So they're just used to seeing more complicated situations.
Mhm.
And so they get on with the business of like helping
Right.
you and seeing you, as opposed to kind of like telling you how they feel about it.
Yeah.
Erica, an MFM, so back in the day, there were OBs and there were high risk OBs. And somewhere in the last decade, that terminology has shifted, and we really don't hear about a high risk OB anymore. We hear about an MFM, which is a maternal fetal medicine specialist. And I find that on the West Coast, sometimes they're called perinatologists instead of
Mhm.
MFMs, but they are the same thing. And somewhere in the middle of the country that must like cross over, but I don't know where that like dividing line is. And it used to be that when you saw a high risk OB, they were the doctor who cared for you and also delivered your baby. But around the same time that the names started changing, the specialization has gotten more distinct. And so now what almost always happens is that you see an OB who will manage the more day-to-day stuff and will be the one, or their team will be the ones that deliver your baby. And you also see an MFM. And seeing the MFM, you see them infrequently in the beginning. You probably have like an early appointment with them, like Christina, we're talking about for you. And then you see them at regular intervals throughout the pregnancy that are probably a little closer together in the first trimester, and then they're further apart in the second and third trimester, depending upon what you're dealing with. They could increase in frequency as you get closer towards the end as well. The MFM's office, not only are they more like comfortable dealing with girls who are on medication, or girls who are older, or girls who are having multiples, or a host of different things, they also do additional testing. And it's nice to have access to that testing. So sometimes girls who aren't seeing MFMs get access to this testing, but a lot of times they don't. They do things pretty routinely, like an early anatomy scan. So instead of just having the full anatomy scan at 20 weeks in pregnancy, they'll do an earlier one at 16 weeks and the one at 20 weeks. They will do like a fetal echocardiogram for the baby in similar time frame, kind of like the 14 to 18 week kind of like range. And they yeah, they there are other tests, like other blood tests and things that they will also have you do. And then I do think that having a second, having a second person weighing in on and like giving advice and opinions on what's going on in your pregnancy is helpful. Like I always use this example. I have a patient who she has a son, and then they tried really hard to have another baby, and they eventually decided to use donor eggs, and she got pregnant with twins at 48 with donor eggs. And she was seeing an MFM and an OB, and her OB just clearly was not really comfortable with the pregnancy. And I sort of wish that she had said, I don't want to do this, you should find another doctor, but she didn't do that. So she managed the pregnancy the whole way through, but every time my patient went to see her, she got upset by the way that the doctor spoke to her, because everything that they were tracking was alarming to the doctor. And then she would see, at 48 with twins, she was seeing the MFM pretty regularly. She would see the MFM 2 weeks later, and they'd talk about the exact same things, and the MFM would put it in a different light, like not just dismissing it, saying that the thing that they were looking at wasn't important, but saying like, but everything's going well, and we're watching this, and we're doing everything we need to, and this is how we're going to move ahead. And like, my patient would go home from that appointment and feel like, the world wasn't ending, like she was okay. So I do think that sometimes having that second voice that is more comfortable with more complicated stuff is really valuable. Any other things about the thyroid, Christina? I know we went over a couple minutes.
No, thank you. I just wanted to thank you.
Yeah.
And also, like, I just wanted to say an extra thank you, because this whole journey kicked off with me working in the October reboot that you ran. So I just feel very grateful. So it's kind of like amazing to be here talking to you about this full circle. So
glad. I'm going to tell all these girls today that have all these health questions that I can't really answer in this food, Q&A, that they should consider coaching with us. Like, I'm not trying to sell people something, but more like everyone needs a personalized kind of approach, and everyone really needs access to people that they can ask for help and ask to explain things, and like that isn't just available in the out there for free for everyone, even though it should be. So I'm so glad. And I will see you guys all. Anyone else have any other quick questions? Anything you wanna ask? Okay, good. Well, I will see you guys all in your various group sessions, and if you're in the reboot, I'll see you there. If you come back to these question and answer sessions, I'll see you there. And I hope everyone has a great weekend. And we're all sending you, Christina, so much love and so much luck. And we're ready for everyone else to be, on the same path with you in our own time, right? So everyone have a great rest of your weekend. And I will talk to you soon. Bye.